Welcome. My name is Scott Suko. I'm the Executive Director of the Northeast Ohio Liver Alliance, and we are glad that you're here for us for another episode of our live liver roundtable. And tonight's focus is on alcohol-related liver diseases. We have a great program for you, and we're excited that you're able to be here. The Northeast Ohio Liver Alliance is a nonprofit founded just this past year, and right here in the Ohio area. And our focus is to educate healthcare professionals and laypersons about liver disease, which fits in perfectly with tonight's learning agenda. We also advocate for resources, public change, and public health interventions that prevent and positively impact liver disease. We also support research and public health interventions that benefit people living with liver disease. So everything that we do is about creating liver wellness and preventing liver disease. And we start a discussion tonight with that in mind. I'd like to introduce our moderator from Cleveland Clinic, and that is Dr. who's going to lead us through and talk about how alcohol-related liver disease impacts our community. And we're going to learn through some case studies as well. So, Doctor, I'll pass it on to you.
Thank you, Scott. Hi, everyone. I'm Shreya Sengupta. I'm one of the transplant hepatologists at Cleveland Clinic, and I was invited to moderate tonight's discussion, the live virtual roundtable on alcohol-related liver disease. So we're going to have three different speakers to talk about various aspects of it. So we have Dr. Rinjal Brahmbhatt from North Shore Gastro, who's going to talk about the burden of alcohol-related liver disease. We have Dr. Bolin from MetroHealth, who is going to discuss diagnosis of alcohol-related liver disease. And we have Dr. Anthony Post from University Hospital, who's going to discuss treatment options. And then finally, we have Arjun Chatterjee, who is a second-year internal medicine resident at Cleveland Clinic, who's going to present some cases. And that part really is designed to be interactive. So there are going to be, I'm going to help prompt discussions, and I won't be shy about calling on people to facilitate it. So I think to start, we're going to start with Dr. Rinjal Brahmbhatt, who's a gastroenterologist and hepatologist at North Shore Gastroenterology. Thank you, Dr. Brahmbhatt.
Right. Thank you for having me, and thanks everyone for joining the webinar, and also to Scott for organizing this all. Are you able to see my screen? Okay. All right. So again, I'll be speaking about the burden of alcohol-related liver disease. So alcohol abuse and dependence are major public health problems in Western society. There are about 2.4 billion alcohol users globally, and when you consider that yesterday the world's population reached 8 billion, that's a significant proportion. Out of these, about 950 million are considered heavy drinkers, meaning 4 or more drinks for women per occasion or 5 or more for men per occasion. The lifetime prevalence of any alcohol use disorder is about 5 to 8%, and the prevalence of cirrhotic and non-cirrhotic alcohol liver disease in the US is about 2%. Alcoholic liver disease can present as a broad spectrum of disorders ranging from fatty liver to alcoholic hepatitis and cirrhosis, as well as hepatocellular carcinoma. About 25% of patients with fatty liver or fibrosis related to regular heavy alcohol use can progress to cirrhosis. With alcohol-associated cirrhosis and liver cancer, about 1% of these cases attribute to all deaths worldwide, with the burden expected to increase in the coming years. Alcoholic liver disease is thought to be responsible for nearly half of liver-related mortalities globally, and in 2017, the global prevalence of alcohol-associated compensated and decompensated cirrhosis was 23 million and 2.5 million, respectively. Globally, in 2010, alcohol attributable liver cirrhosis was responsible for 490,000 deaths. Alcohol attributed liver cancer was responsible for 80,000 deaths. And with comorbid liver disease, such as hepatitis C, non-alcoholic fatty liver disease, as well as hemochromatosis, alcohol use appears to accelerate liver damage and hepatic decompensation in those with existing cirrhosis. In fact, in one study in hepatitis C patients with alcohol use disorders, there's about a 4-fold increased risk for decompensation in these patients. This is a map of the world that shows adult per capita consumption of pure alcohol. And as you can see, there's a geographic variation in the amount of alcohol used. So the lowest rates of usage are in the Middle East as well as Northern Africa, with higher rates in Eastern Europe as well as Russia. And interestingly, in Southeast Asia, the rates are actually increasing. And the reasons for these include demographic, religious, and cultural factors, as well as the level of economic development in that country. As far as US burden, a 2019 National Survey on Drug Use and Health found that 80% of participants used alcohol in their lifetime. About 51% of participants used alcohol at least once in the prior 30 days. 24% reported a heavy drinking episode, meaning 4 or more drinks for females or 5 or more for males in the month prior to the study. And this was classified as a binge episode. About 6% of these participants reported heavy alcohol use, meaning 8 or more drinks for females or 15 or more drinks for males in the month preceding. Interestingly, nearly 3 in 10 adults in the US use alcohol in an unhealthy manner. Additionally, the National Institute on Alcohol Abuse and Alcoholism in 2005 had a study looking at the rates of alcohol consumption among US adults. 28% of the participants exceeded the NIAAA thresholds for risky use, meaning 4 or more drinks daily for men, 3 or more daily for women, or 14 or more per week for men, or 7 or more per week for women. 19% exceeded just the daily limit, and 9% exceeded both the daily and weekly limits. Additionally, data from the 3rd National Epidemiologic Survey on Alcohol and Related Conditions found that 14% of adults met criteria for a current alcohol use disorder, and 29% met criteria for an alcohol use disorder at some point in their life. The risk factors for lifetime alcohol use disorder include male gender, a younger age, Native American and white ethnicity, having a significant disability or another substance abuse disorder, as well as mood disorders and personality disorders. In terms of alcohol-related cirrhosis, there was an interesting study in 2015 looking at privately insured US cohort of a national, that was thought to be nationally representative of patients with alcoholic cirrhosis. About 94,000 of these patients had cirrhosis, and 105,000 of these had alcoholic cirrhosis. The mean age at diagnosis was 53, and about 30% of these patients were females. Over the 7 years that were evaluated, the estimated national cirrhosis prevalence rose from 0.19% to 0.27%, which was a 43% increase, and for alcoholic cirrhosis from 0.07% to 0.1%. Compared to non-alcoholic cirrhotic patients, alcoholic cirrhotic enrollees were significantly more likely to have portal hypertensive complications at diagnosis, higher yearly cirrhosis and alcohol-related admissions, as well as all-cause readmissions. And the per-person cost in the first year after diagnosis nearly doubled for alcoholic cirrhosis compared to non-alcoholic cirrhosis, a difference of $44,000 versus $23,000. They also found that alcoholic liver disease mortality increased in patients aged 25 to 34, rising 15% over a 10-year period. In terms of alcohol-associated hepatitis, the incidence here is a little more difficult to estimate, given the diagnostic accuracy of administrative coding being a little less reliable. Alcoholic hepatitis carries a particularly high rate of mortality, reaching up to 50% in severe alcoholic hepatitis. In 2016, approximately 21.5 million years of life were lost due to alcoholic liver disease, and these years were lost primarily due to premature death as opposed to disability. The overall number of hospitalizations and overall inpatient costs of individuals with alcoholic liver disease have also increased over the last 10 to 15 years. In 2002, there were 250,000 alcoholic hepatitis-related hospitalizations, mostly due to hepatic encephalopathy, and in 2010, this number rose to 320,000. There is a trend towards more serious illness and an increased risk for readmission for liver-related issues in these patients. So in summary, the global alcohol trends for some populations are decreasing, but for others, including women, they appear to be worsening, especially among active drinkers. In the US, alcohol consumption is increasing, particularly among women, minorities, and those living in rural areas. These trends threaten to worsen the burden of alcoholic liver disease. Deaths related to liver cirrhosis are projected to triple by the end of 2030, driven largely by increasing prevalence of alcoholic liver disease and non-alcoholic fatty liver disease. And efforts to decrease problematic alcohol use at the policy and patient level are urgently needed. For example, the WHO has an initiative to address pricing policies and restrictions on alcohol availability and marketing, and ultimately that could help reduce the burden of alcoholic liver disease.
Thank you, Dr. Brahmbhatt. I think we'll probably try to save questions for the end. So next is Dr. Bolin from MetroHealth. She's a hepatologist at MetroHealth, and she's going to be discussing the diagnosis of alcohol-related liver disease.
Awesome, thank you. Thank you for the invitation. And I'm going to jump right in. You see my screen, I can just share it. So I'll be speaking about alcohol-related liver disease and its diagnosis. Okay. In overview, I'm going to talk about the definition of alcohol use disorder and then alcoholic liver disease, and then how to ask about alcohol use in your patients, biomarkers that might be useful, and then imaging and whether you would need a biopsy in this instance. So first, going into definitions. So for alcohol use disorder, this is AUD, and it's a DSM-5 diagnosis. It has now replaced the terms that have more stigma attached, like alcoholism, alcohol abuse, and so on. It's defined as problematic patterns of alcohol use leading to clinically significant impairment or distress as manifested by 11 specific areas. And I'm not going to go through that, but alcohol associated liver disease, ALD, now refers to everything on the spectrum, which is alcohol associated steatosis, steatohepatitis, which is really a histologic diagnosis, hepatitis, which is clinical, and then alcohol associated cirrhosis. So ALD sort of refers to the whole gamut. And then this is really the spectrum. So patients can present with alcohol-related liver disease in any of these ways. A lot of times it's very impressive with, acute alcoholic hepatitis. And that's what we see a lot inpatient. And then they can also present obviously chronically, having steatosis to begin with, which leads to inflammation and fibrosis, which leads to cirrhosis, and then eventually HCC. So all of this counts in really ALD. So how do you ask about alcohol use? Because that's such a essential part of diagnosing ALD. So you have to take a good history. Since signs and symptoms of ALD are really the same as any other etiology of liver disease, you must ask about alcohol use in order to make this ALD diagnosis. And the diagnosis of ALD really requires a detailed patient history, as well as supportive lab and imaging studies. So what is a standard drink? I think we all know this, this image by now, but it's 12 ounces of beer, 8 to 9 ounces of malt liquor, a glass of wine, which is 5 ounces, or a shot of liquor. So that's what a standard drink is defined as. And then the AASLD guidance, does say that all patients receiving primary care or GI hepatology outpatient clinics, EDs, inpatient admissions, they should all be routinely screened for alcohol use with validated questionnaires. So really all the time we should be screening for alcohol use and not miss, these opportunities. So how to recognize excessive drinking? There are a couple ways, but the NIAAA has a one question initial screen, which is pretty easy to remember. So in the past 12 months, how many times have you had 5 or more drinks in a day? And that's for men, or 4 or more in a day for women. So that's really screening for binge drinking. So if that's a yes, then you can go on to kind of a more detailed questionnaire. And then there's a 3-question audit C, which could be useful as well. So in the past 12 months, how often did you have any kind of drink containing alcohol? how many drinks did you have on a typical day when you did drink, and then how often did you have these binge drinking episodes. So then people would pick from different frequencies, you add the points up, and that gives you an idea of whether they are at risk. And that's the audit C. So then kind of for me, the easiest way is to think about sort of what's low risk drinking. And then anything beyond that is really at risk drinking. So this is again from the NIAAA. They say that low risk is defined as less than 14 per week for men total, and less than 7 drinks per week for a woman. And then also on, this is an and, so it's also less than 4 on any occasion for any single day for a man, less than 3 on any single day for a woman. So if you meet that, then you're low risk, and anything beyond that really is at risk drinking. And you can try to ask more detailed questions at that point. And then other questions to ask are, or at least that I find useful, are like prior rehab detox, any relapses that they've had in the past, any DUIs or problems with the law, and then family history of alcoholism. So I think those are going to be informative as well, when you're thinking about transplant later on. So yeah, so those are how to take a history of alcohol. And then in terms of biomarkers, the goal of a sort of ideal biomarker would be it's easy to obtain, it's cheap, it's sensitive and specific, which I'm going to go into. There are 2 categories. One is biomarkers related to ethanol metabolism. We'll talk more about that. And then ones that are not related to ethanol metabolism, and that would be more like MCV. You could see a macrocytosis with alcohol, and then AST-ALT ratios. So we do know that alcohol, though, if it's causing your liver disease, it should be AST-ALT less than 300. It won't be the super high, 1 to 2,000s. That's not all due to alcohol. And the ratio of AST to ALT should be 2 to 1 or higher. And then in terms of comparing these biomarkers that are related to ethanol metabolism, there are different sources, blood, urine, hair. These are all pretty commonly used, except the hair one. I don't think we use that as much. But I did want to point out one, which is PEth. And I think a lot of programs do use PEth now because it does have a really good interval detection between 2 to 3 weeks. And that lets you pick up patients who are drinking, not just right before they showed up to your clinic, but within sort of a longer period of time. And the sensitivity and specificity are not bad at all. And then obviously PEth also correlates to their level of consumption. So you can look at the PEth level, and that does correlate with how much they are drinking. In terms of imaging and diagnosis, I don't think it's super helpful, but you can see obviously on ultrasound steatosis, a large liver, portal hypertension in the acute alcohol hepatitis setting. And then for FibroScan, I don't use that as much, but in the acute ALC-HEP setting, because it's going to overestimate your liver stiffness. And oftentimes they will have portal hypertension, so you're going to screen them for varices anyways. Sometimes it could be used serially to assess liver stiffness, and now there's some thought about doing spleen stiffness as well. So things to watch out for. And moving on, there is an entity of early ALD that doesn't really have any definitions at this point, but I think we all see patients that sort of have alcohol-associated steatosis and even ALC-HEP, and then that totally resolves with abstinence. We don't really know where the threshold lies. The patients that will end up with cirrhosis and that will not reverse with abstinence versus those that do kind of get to a normal liver. So I'm not sure exactly where that cutoff is, and that's something that a lot of people are looking into. And then lastly, biopsy, diagnosing alcohol-related cirrhosis. I don't think you don't really need a biopsy for that. That's going to be clinical. But for alcohol-associated hepatitis, if it's a possible AH, and then you have some confounding factors, and we're not sure if there's, maybe overlapping Hep C or Wilson's disease, some other factor that's confounding, then you would potentially want a biopsy at that point to confirm alcohol associated hepatitis. So that's a time that you would maybe consider biopsying the patient. But I would say in most cases, you do not need a biopsy for this diagnosis. So in summary, we defined what AUD and ALD are, how to take a good history for alcohol in practice, and then biomarkers, their windows of detection, and imaging findings, and when is a biopsy helpful. And thank you. That's it for me.
Thank you, Dr. New. That was very really good summary of all of the different diagnostic modalities. I just wanted to make a couple points. One is that, we were kind of talking about screening with the single question, the NIAAA single question, and then the audit C, just as a refresher, that's still a screening, and then you still need a formal assessment to formally, diagnose an alcohol use disorder. Like Dr. New said, that's an 11-part question. I'm impressed if anyone has the time or the workflow in their office visits to do that. I still haven't figured that out. And I really do rely on social work and our, psychiatry colleagues to help with that. The other thing that I thought that was interesting was just looking at the PEth cutoffs that you had up, because I think that does highlight once again some institutional variability in even how to interpret that test. And I think that'll come up later. And I think those were my 2 points. So thank you, Dr. New. And last of the sort of didactic or sort of the presentations is Dr. Anthony Post, who is a hepatologist at University Hospital and the medical director of transplant. And he is going to be talking about treatment for alcohol-related liver disease.
Okay, thank you very much. Let's see here. Do slideshow in the beginning. There we go. So I'm Tony Post. Thank you so much for the invitation to speak on one of my favorite topics. So we're going to talk about treatment of alcoholic liver disease. So now we know there's a tremendous burden. We can diagnose it in our patients. So what can we do about it? Well, we're going to talk about different aspects of this and different forms of alcoholic liver disease. We need to get our patients to stop drinking alcohol. We need to evaluate their nutrition. We need to consider treating alcohol hepatitis if it's present, and then when could we consider a transplant option? So we can do probably a whole seminar on each one of these, but we'll try and run through them rapidly. So clearly the main gold standard of treatment for alcohol liver disease is to stop drinking alcohol. The liver will get better usually if they stop drinking alcohol. There's usually a component of alcoholic hepatitis, even in alcohol cirrhosis if the patient's been drinking recently. So when you stop them from drinking alcohol, if they've been drinking heavily, the first thing you have to do is watch for withdrawal from alcohol. So if they have a history of delirium tremens in the past, if their age is over 30, if they have concurrent illness such as pneumonia or sepsis or SBP, they're more likely to develop withdrawal symptoms. And if they have significant intoxication on admission, they're more likely also to go on to have alcohol withdrawal symptoms, which we should watch for because they have a fairly high mortality. You don't want to stop the patient from drinking and have them die because you stop them from drinking. So if you manage them appropriately with hydration, thiamine, folate, multivitamins, and treat their psychomotor agitation with lorazepam or some other benzodiazepine, usually you can get them through this period. Once they're out of the danger zone from alcohol withdrawal, you need to assess their support systems to maintain sobriety. So stopping alcohol is one thing, but maintaining sobriety is quite another. And I think many patients have stopped drinking, but they do tend to go back to drinking, and having adequate support systems is really key to preventing this from happening. Family, friends, prior Alcohol Anonymous treatments or other treatment programs, intensive outpatient programs are often very helpful in this situation, particularly if the patient recognizes their alcohol dependency issues. It's important for the patient to avoid alcohol and to have family members avoid alcohol, and we need to refer the patient to an alcohol treatment program. So once we've stopped the patient from drinking, patients who consume alcohol heavily are often very malnourished despite getting calories from ethanol. They oftentimes are both protein and calorie malnourished. So we need to make sure that they're getting adequate calories. 35 kcals per kilogram a day is recommended, along with 1.2 to 1.5 grams per kilogram of protein a day, which comes out to about 60 to 100 grams of protein a day, which is quite a bit. And that's probably a dozen eggs of protein a day. So they really need to increase their protein intake to both regenerate their liver and also to help regenerate muscle mass. A lot of these patients have degenerated muscle mass and fragility. If possible, this should be done with oral meals, and evening protein snack is advisable. It's better used than during the day, so giving protein at night is more readily available. If necessary, nutrition can be given through an enteral feeding tube, and in the profoundly malnourished, it probably should be given in that manner. Once we diagnose our patient with alcohol hepatitis, if they have inflammation in their liver, their bilirubin is elevated, they've been drinking recently, we should calculate a discriminant function, or so-called battery discriminant function, to assess the severity. This is the bilirubin plus 4.6 times the prothrombin time minus the control prothrombin time in your institution. If that number is over 31, it indicates severe disease with a possible or a more increased likelihood of mortality for that patient, and you should consider those patients for treatment, other than nutritional treatment that I talked about earlier. Many papers and meta-analyses have looked at treatment with corticosteroids. My general rule of thumb is that there's no contraindication. Patients should get a trial of corticosteroids, usually prednisone or 32 milligrams of prednisolone. And if the bilirubin doesn't fall by day 7, so-called Lille score doesn't fall, then you can probably stop the prednisone. If the bilirubin does fall and Lille score falls with it, you can continue it for 30 days. And I think we have a case to discuss this in a few minutes. Contraindications and relative contraindications to corticosteroids include active gastrointestinal bleeding, active infection, renal failure. In these situations, it's probably futile to use steroids. The steroids may make these conditions worse, and the mortality really is much higher, and probably not going to get the benefit from the steroids, but you're going to be subjecting those patients to the risks of corticosteroids. You can wait up to 7 days to monitor for these things. They don't have to be started right away in the studies. I think it's useful to kind of get an idea of where your patient is before you start them on prednisone or prednisolone. So here's the 800-pound gorilla in the room, the liver transplant in patients with alcohol-related liver disease. They need an excellent support system to qualify. They need to have a commitment to lifelong sobriety. You certainly don't want to go transplant somebody with alcoholic liver disease who's going to go back and drink and destroy their new liver, and this can happen quite rapidly after they are transplanted. So we really don't want that to happen. It's bad for the patient, it's bad for their family, it's bad for your program, it's bad for society. So I really don't want that to happen. For chronic alcohol liver disease, patients should be in a treatment program prior to the transplant. They should demonstrate at least some level of sobriety prior to moving forward with transplant. if they have chronic liver disease. In acute alcoholic hepatitis, sometimes they don't have the opportunity to go into a treatment program. So recently, there's been literature that suggests that if patients have never been told to stop drinking in the past, they have commitment to lifelong sobriety, they have a supportive family, and they agree to enter a treatment program. After transplant, they may actually do quite well with transplant. And this is the Sentinel paper from the New England Journal in 2011. It's over a decade old now, but really changed the way a lot of us thought about liver transplant and alcoholic liver disease. What we have here is 3 groups. The top group is patients who responded to corticosteroids and therefore did not need to be transplanted. They go out to 6 months and they have an excellent survival. The 2 other groups are groups that did not respond to corticosteroids. One group went on to receive liver transplant and also had an excellent survival. And this other group is a group that did not respond to corticosteroids, but for one reason or another either did not receive a liver transplant because one wasn't available in time, or that they did not qualify for this protocol because they either didn't have commitment to sobriety or didn't have good family support. And we can see that the survival difference is really markedly different even at 6 months between the group who did not get transplanted and the group who did. So in summary, not the summertime, but summary, patients need to stop drinking alcohol, by far the most important thing that they can do. Watch for treatment withdrawal, optimize their nutrition, particularly protein calorie malnutrition, treat with alcohol hepatitis with corticosteroids. I think most patients probably qualify for at least a short course of corticosteroids to see if they help. And in the non-responder with acute alcoholic hepatitis, who has good prognostic risk factors for not going back to drinking, they should be considered for liver transplant. That's all I have to say.
Thank you, Dr. Post.
Thank you.
Before we move on to the cases, I wanted to ask a question that maybe is just my, just something I wonder. What does everyone use for a control PT when calculating the MDF? Just out of curiosity.
So I look at the, I look at the lab sheet and I use the highest normal of the range for the lab, which is reported back.
Okay.
But you're right, it is a little bit subjective. I think it was subjective in the paper too.
Dr.
So
Brahmbhatt,
could I make a comment about that?
oh, sure, Dr. Curry, go ahead.
So this very question came up about 8 or 9 years ago in our liver group. And I did a little survey of our hepatologists about what control value do you use? Upper limit of normal, mid-range, or something else? And we got a whole range of answers from our group. And one of our internal residents said, well, why don't you just ask Dr. Madre? So I sent him a note, and he took a few days to get back to me. And he said, well, I'm sorry I took so long to get back to you, but I didn't really know the answer to that. So I asked my fellows, and they said you ought to use the mid-range of the control. And if you go back to his original study, there was a much narrower gap between the lower limit and upper limit of normal for controls. Now it's broad enough that when you multiply it by 4.6, you get vastly different numbers. So Dr. Madre, after some reflection, thinks the mid-range is what you should use.
Okay, all right.
I'll accept it.
Looks like we have 2 questions for Dr. Post. One is medication assisted treatment. Does that mean treatment for alcohol use disorder or other?
Yeah, I think I put that in the box. There's been some talk about medication assisted treatment. I'm just wondering where you see that intersection with your work.
Yeah, so I didn't get into that because there's a whole controversial large literature about that. I think I would encourage the medication assisted abstinence to be through an abstinence program, because I think it really works better if they have both counseling and medication. it's hard just to give the patient medication and hope for the best. Disulfiram probably shouldn't be used in this situation, in any circumstances, because it can cause very serious liver problems. But other things have been proposed, and I leave it up to the chemical dependence program. Good
Great.
question.
I think for the sake of time, and because I do think that the case presentations are going to generate some good discussion, I think we can move on and maybe circle back to some of the questions that are popping up at the end. So last but not least is Dr. Arjun Chatterjee, who is a second-year internal medicine resident, and he at Cleveland Clinic, and he's going to be presenting 2 cases. And we've got sort of built-in areas for discussion. So he's going to present, and after a couple slides, I'm going to kind of prompt some discussion to keep things interactive. So Dr. Chatterjee, thanks for putting together these cases.
Thank you for the opportunity, Dr. Sengupta, and I want to thank Neola for giving me this stage, presenting this, share my screen. Are you guys able to see my slides?
Yes.
Perfect. So the case 1. So case 1, 40-year-old female with past medical history only significant for 5 C-sections. That to the last C-section was 10 years prior. Presented to the emergency department at another hospital with nausea and vomiting for a week, and also had scleral icterus. So on presentation, her labs were a total bilirubin of 29.7, high LFTs, alkaline phosphatase of 128, high AST of 249, and ALT of 67, and the lipase was slightly high, but not higher than 3 times normal. It was 131. Liver serologies were done. It was all negative. So negative acute and remote hepatitis panel. Transferrin saturation was 83. Creatinine was 140. Normal ceruloplasmin. ANA was slightly high at 1:320. But AMA, smooth muscle, and LKM were all negative. On presentation, an abdominal ultrasound was pursued at the other hospital, which showed hepatomegaly, some colloidal stone polylithiasis, common bile duct measuring 3.8 millimeter, no intrahepatic biliary dilatation. She stayed there for a total 5 days prior to transfer. MRCP was pursued on day 3, which showed cirrhotic liver morphology, probable steatosis, no intrahepatic or extrahepatic biliary dilatation, and no filling defects in the biliary tree, and confirmed the polylithiasis. So
what is the diagnosis? So Dr. Chatterjee, if you go back to the previous slide really quickly, maybe Dr. New, since you discussed diagnosis, maybe I'll call on you for this one, but you see the labs, you see that there's an elevated transferrin saturation, you see a positive ANA, you see the imaging. How do you put it together, and what's your best guess?
Yeah, so definitely need to ask about her history with alcohol. I think that's going to be really informative. Not just acute history, but also chronic history. And then, any medications that she's been taking recently, anything new, any herbal supplements, because we don't want to just kind of assume that she has alcohol. So always rule out other things. And it looks like it says negative. Is it acute hepatitis as in acute viral hepatitis or negative?
Correct.
Yeah. So make sure that's not the case. I mean, I'm not so worried about the 1 to 320 for the ANA, given the negative smooth muscle. I don't think this is autoimmune hepatitis. And then you also ruled out like biliary dilatation and biliary obstruction. So I think, ask her about the medications and then an alcohol history.
Great. And Dr. Chatterjee took out one piece of the clinical presentation, which was, you can give that social history, Arjun.
So yeah, the patient, unfortunately, the patient lost her sister a couple of weeks back to this presentation and started using alcohol heavily. She also had prior history of alcohol use.
Okay.
Do we know what the albumin and the total protein is, for what the immune globulin fraction is?
We didn't include that in this presentation.
Okay.
And any specific reason, Dr. Post, you're asking?
Yeah, so if the immune globulin fraction is very high in a young woman with a positive ANA, I still would have in the back of my mind that this could be autoimmune hepatitis, and I wouldn't want to make that mistake. And obviously they could have autoimmune hepatitis and alcoholic liver disease. So A high immune globulin fraction would make me a little suspicious about autoimmune hepatitis. Yeah.
I think in her case, her total IgG actually was elevated. But I can't remember exactly how much, whether or not it was slightly above the upper limit of normal, 1.5. But I think Dr. Chatterjee, you can keep going with what happened next.
Sure. So she was transferred to the Cleveland Clinic main campus on day 5 for further evaluation of liver transplant. On presentation, so we did not have the labs. So on presentation, we calculated the MDF, which was 52. Mel sodium was 27. Steroids were not prescribed at other institutions, and we did not prescribe steroids either, as our total bilirubin was trending down. We pursued our transtubular liver biopsy day 7, so that was our second day, which showed steatohepatitis with early bridging fibrosis and a sinusoidal pressure of 7 millimeters of mercury. EGD with US was also done, which did not show any varices except some portal hypertensive gastropathy. And she stayed at the Cleveland Clinic for 2 days and was discharged with close follow-up.
So my question to the group is, who would have prescribed steroids? Who would have biopsied? So Dr. Post, you're raising your hand. You would have prescribed steroids, and would you also have biopsied?
Yeah, I mean, yes. So I would have prescribed steroids because this is a pretty sick patient. And she may look okay, but she's, has probably close to 50% mortality, even if her bilirubin has come down a little bit. Yeah, I think a biopsy would be helpful. I would still have a little bit of concern in my mind that she had autoimmune hepatitis, and I think the biopsy pretty much excludes that diagnosis. So I would feel more relieved by having a transjugular biopsy myself.
Dr. Brahmbhatt, Dr. New, would you have started steroids? Would you have relied on a biopsy in this situation, or would you feel like you've got enough information to kind of have a diagnosis at this point?
I think based on the discriminant function being high, as well as the high MELD, I would have started steroids as well. It sounds like she had she was in the hospital for 2 days. Is that correct?
At this point, she'd been there for 2 to 3 days.
Okay. I think I would have seen what her allele score was at day 7 and decided whether or not to continue. But given those parameters, I would have prescribed steroids. And also for the same reason Dr. Post discussed, given that she's a young female, I think it'd be important to rule out autoimmune hepatitis in this situation as well.
I think I'm a little more conservative with maybe steroids. I think for someone who is going to follow up, like I would probably prescribe steroids, but she has to be someone I trust that's going to come back to get the allele score labs, because a lot of times we have patients that we prescribe and then they just leave and they never come back, and we don't know what happens to them. So they sort of have to convince me that they're going to show up for the allele score labs. And then the other thing is that I would probably do like all the infectious workup first to make sure that she doesn't have any infections, and like wait for 48 hours for the negative blood cultures, and then, decide on the steroids. But yes, I agree with the biopsy. I would do that.
And if let's say this patient had come in and was there at one institution for the whole time, and this kind of ties in with one of the questions I think from Dr. Carey, would you calculate the allele score at 4 days and decide whether or not to move forward, or would you wait a full 7?
I think there's a pretty good evidence for 4 days at this point. So I would do 4 days.
Dr. Post, Dr. Brahmbhatt, what's your practice?
I still wait till day 7, but yes, the data for day 4 is good as well. So that's completely reasonable.
I wait for 7, but I could easily be convinced to look at 4.
Okay.
Can I just ask though, that EGD with EUS, do you guys always do it with EUS, or is it just to look for the gastric varices? I mean, is it typical for you to do EGD with EUS for this case?
It's not standard of practice. I think there was, I'm trying to remember why I took care of this patient. I'm also a little bit conservative with steroids, and I kind of have the same approach as you do, Dr. New, which is if you're not going to show up, I'm probably not going to, if I don't know that you're going to come back, I might not prescribe them. I cannot remember why we did the EUS, Dr. Chatterjee. Cherry,
Yeah.
did you see that, why we did EUS?
Yes, so the MRCP, which was done at the other hospital, we did not have the results with us, but there was some concerns on the discharge paperwork that I think there was some like biliary dilatation, which the MRCP mentioned. That's why she was being transferred for cholelithiasis with suspicions for cholangitis with higher CPC. That was probably another reason why she was not started on the steroids, and she was being transferred like
Yeah,
possibly.
not unreasonable in someone with gallstones who has a bilirubin of 29 to take a look at the distal common bile duct and make sure you didn't miss something there. I think that's not unreasonable. I was wondering about that too, but no, I think that's very reasonable.
Okay, great, thanks for that history, Arjun. I think we can keep going.
So she was followed up. She followed up with Dr. Sengupta after 1 week. This time she was diagnosed with cellulitis of her lower legs, treated with antibiotics. Her INR was still high at 2.0, and total bilirubin was still high in the upper 30s. So after that, she followed up virtually at 3 months since the admission. This time she needed to be started on spironolactone 50 milligrams a day for fetal edema. Total bilirubin came down significantly to 8.6, and INR was still high at 2.0. She was abstaining from alcohol during this whole time. We encouraged her to pursue IOP, but she was unable to do so, and we handed her the resources for local AUD, but it was unclear whether she pursued those. So further follow-up. So she had another virtual visit at 9 months, and this time her icterus and pedal edema had significantly improved. She stayed absent from alcohol. Her MELD sodium score fell to 17. TBD was slightly high at 3.2. INR was still high at 1.8. A liver elastography was performed this time, showing F4 fibrosis and steatosis of grade S2. Liver ultrasound was also performed, showing patent hepatic vasculature, no overt appearance of cirrhosis. The cholelithiasis was still present. And then she came in for an in-person visit a month later. Her TBD again went down to 1.9. INR was improving at 1.6. MELD sodium now was 14, and she was still absent from alcohol.
So this was probably like best case scenario. A better case would have been engaged in alcohol use disorder treatment. Better case would have been, I did a lot of virtual visits with her while she was out fishing with her kids, so trying to figure out how icteric are your sclera. But in terms of continued alcohol abstinence, in terms of sort of natural resolution of her hyperbilirubinemia and cholestasis, kind of the best case scenario. So I thought this was an interesting case to kind of discuss that not everyone gets AUD treatment. Some people do stay abstinent, still better data for treatment than not. And sometimes this resolves. There's a high mortality, but some people do okay. I don't know what the overall takeaway is, but this is one case that turned out well.
Can I make a comment just
Yes.
briefly? So I'm still worried about this patient. I think she's doing great now, and I would encourage her, but I think that she does have a substance abuse disorder, and I'm not sure that she has very much of the skills needed to maintain lifelong sobriety. It's great that she's been sober for 10 months, but I've seen lots of patients like this who go back to drinking and end up where they were before. So I would still encourage her to enter a treatment program, and I would congratulate her on how well she's done so far, but also say she needs some more.
Definitely. It's an ongoing discussion.
Yeah.
All right. The second case is a little bit more controversial, so I'll let Dr. Chatterjee get started.
Yes, so the second case is that of a 35-year-old female with past medical history of alcohol-related cirrhosis, complicated by portal hypertension and all of its complications, ascites, SBP, hepatic encephalopathy, HRS, thrombocytopenia, also had history of GERD and substance use disorder. She used to stay in New York City and was initially admitted there at a New York City transplant center with decompensated cirrhosis, secondary to alcohol use in early 2018. With a readmission at another hospital in New York in 2019 with hepatic encephalopathy. After that, she moved to Ohio to stay with her family, did IOP for 2 months, and stayed sober for almost 2.5 months before relapsing and getting admitted for alcohol-associated hepatitis, eventually requiring intermittent hemodialysis for HRS. She was transferred to the University of Cincinnati for liver transplant evaluation, where she was turned down. And then she was referred to 7 other centers where she was not accepted for liver transplant, and eventually accepted by Cleveland Clinic Foundation for SLK evaluation in early February of this year. Her MELD sodium score was 36 at the time of transfer.
So I think the question for our panelists is, let's say you get this call. This is a patient with a young female, long history of alcohol use disorder. What we don't tell you in there is that she was actually evaluated in 2018 and was actually was on dialysis at that point, and then improved with sustained abstinence and was able to come off the list at the New York Transplant Center, and then was lost to follow-up and then kind of reappeared again in early 2022. She gets turned down for transfer. She wasn't evaluated at 7 centers, but turned down for transfer at 7 centers. So if you get this call, would you accept this patient for a liver kidney evaluation? Dr. New, what do you think?
Ooh. She's clearly very sick. Is she able to, is she encephalopathic? Like, is she able to give a history and, engage with the team, with the social workers about her history pretty well?
So the report we're getting is that she's alert and oriented times 2 to 3. She is not on any respiratory support and on a regular nursing floor.
Yeah,
That's kind of it.
it's hard to say, because I would probably say no, just because she's obviously shown that she's relapsed. She relapsed probably, multiple times, it looks like, right, in 2018, and then another 2.5 months before this all happened. And then she's moving, so it seems like maybe she doesn't have stability in her life. I'm not sure what her support system is like. And then how long was it in between, I guess, the February 2022 and her presenting this time with ALK-HEP? And was she admitted this whole time?
So I believe 2 or 3 months, prior to February, she got admitted at one of the other centers prior to being transferred to University of Cincinnati. So she showed up with ALK-HEP in maybe November or December of 2020.
Okay, so it's been 3 months and she's been inpatient this whole time, sounds like.
Yeah, I think she left EMA for 5 or 6 days and came right back.
Oh, okay.
Dr. Post, do you have a verdict on whether or not you'd accept this transfer?
Well, yeah, so this is kind of a bad scenario. So I guess the simple answer is, yeah, I probably would accept it, but I would tell them it's very unlikely that we would offer them transplant. What she has that doesn't fit our protocol is relapsing after a treatment program. So in terms of transplanting someone for alcoholic hepatitis, she wouldn't meet our criteria. That doesn't mean that she couldn't, be sober and get better and maybe go into a treatment program and then be considered for a transplant. We would not offer her a liver transplant for acute alcoholic hepatitis. But so would I accept her? I'd accept her for care with the understanding that she would not likely get a acute transplant in the acute setting.
Dr. Brahmbhatt, any thoughts?
With the caveat that I'm not at a transplant center, I would accept her for care, but I think given what was already discussed in terms of her having relapse, and only being abstinent for 2.5 months after doing IOP, and also, as Dr. New mentioned, her moving around from state to state does suggest that there's some maybe lack of psychosocial support. So I think it would be unlikely that she would be a good candidate for a transplant eval in that setting.
Okay.
Can I ask Mary Panko what we would do?
I don't get to make the decisions. So since I'm just
Okay.
the coordinator, I would say that depending upon who was on service at our center, we might have been one of those 7 that turned her down. Of course, it wouldn't have been Dr. Post on service. Someone else may have done that.
Maybe somebody else.
So Dr. Chatterjee, I think you can keep going with what happens next.
So she was transferred to the Cleveland Clinic, eventually ended up having a 92-day stay at our institution. So came right into our Cleveland Clinic ICU requiring renal transplant therapy, was placed on CVVHD. Her ICU course was complicated by spontaneous bacterial peritonitis, hepatic encephalopathy. She also had ascites requiring paracentesis. We did an EGD after she came in, which showed esophageal candidiasis and a suspected dural violation versus an atrial venous malformation. It was injected and clipped, but no varices. She was also diagnosed with celiac axis stenosis on a CT scan of the abdomen. This was not intervened on. The patient underwent a formal transplant evaluation. Her MELD sodium was still 35, and she was deemed not suitable for liver transplant due to her history of ongoing alcohol use. So she was being, Dr. Sengupta, do you want to ask a question or do you want me to continue?
No, I think you can keep going. I was going to say something, but no.
Sure. So she was being closely followed by our psychiatry and social work while still in the ICU after she was being rejected from being transplanted. And she started smart recovery in early March while still being in the ICU. Her MELD sodium was still in the high 30s. She was then again reevaluated for liver and a kidney transplant at the beginning of April. And then she was finally approved and underwent a diseased liver transplant 3 days after approval and kidney transplant the following day.
So I think the question here is, what does everyone think about this decision to transplant the patient? How would this have gone with the limited information we've given you? What's the trajectory at your center?
What's the
Pardon?
SMART evaluation that she had?
Smart
Maybe
recovery.
wasn't so smart. What was the?
Smart recovery, I think, is sort of a non-spiritual alternative to AA. So it was one of the virtual AUD treatment options that were available to her. Because unfortunately, an IOP is not, even a virtual IOP is not an option, was not an option because of her inpatient stay.
Okay.
So her sobriety was basically maintained by staying in the hospital, and she could not have alcohol because she was hospitalized.
Correct.
Yeah.
This is a mess for the coordinators.
Right. Right.
I don't like it. I wouldn't have liked it. I think these are the kind of patients that you don't know because they're only in your institution, and then you can't really predict what they're going to do outside, and it's really a toss-up whether they're going to do okay or not. And she doesn't even live in Cleveland. So at least I mean, I guess I don't know where she lived, but in Ohio, but.
Right. So she relocated to Ohio actually to be closer to family. She had actually found a more stable job in Ohio and had father's side of the family in the Cincinnati area and mother's side of the family in Cleveland. So she did have some ties to the area.
Oh, that's good.
Yeah.
A place to stay.
Yeah. So I mean, I'm all for giving a 35-year-old person a chance. I think this is really going out on a limb. I think we have a lot of poor prognostic factors for continued sobriety in this patient. And having said that, sobriety isn't everything, and she may survive even if she goes back to modest drinking. But I wouldn't transplant her with that understanding. I think in our program, we would say that this patient is too high a risk to be transplanted. And we would have gone a little bit longer, recognizing the fact that she might not survive, by trying to get her into a more formal program. It's a very tough decision in a young person like this, particularly if they have a very good supportive family.
I think Dr. Kim is one of our new transplant surgeons. I think he's still on the call. Recently joined us from Massachusetts. Dr. Kim, what would you have done in this situation? Were you involved in the case?
I think it's kind of judgment call, because actually I have a same discussion when I was in fellowship, and we have a discussion about whether they're gonna do the transplantation or not for this kind of a situation. And so I was actually against for the transplantation, but the most of the program actually they are doing the transplantation like this situation. So basically, if that goes to the surgeon and they probably yes for the transplantation, that's kind of current situation right now, I'll say.
Dr. Carey, any thoughts? I usually call on you in any meeting that we're in together.
Well, you don't have to. But I mean, I would agree with the sentiment that's been expressed so far. This was really somebody who seems to be outside the rules that most transplant centers have established for exception calls for alcoholic liver disease. I guess the longer somebody stays in your hospital, the more attached you get to them, and you may make decisions that are different. But this is not a very good precedent for rulemaking and rule following. I hope she did well.
So I think we can keep going with some more updates in Dr. Chatterjee's presentation.
So after the transplant, she required a tracheostomy and was decannulated prior to transfer to the regular nursing floor. Initially started on TPN, was slowly transitioned to DIU feeds. She also required renal replacement therapy for almost a month in the CQ, and then eventually transitioned to intermittent hemodialysis. Nephrology was consulted, a kidney biopsy was performed, which showed ATN. Eventually, she was transferred to the regular nursing floor and discharged from the hospital to acute rehab on intermittent hemodialysis, where she stayed for over a month receiving acute rehab. So long-term follow-up wise, the patient was started on prednisone, mycophenolate, tacrolimus. She was also started on acyclovir, fluconazole, and Bactrim for prophylaxis. Buspirone was prescribed for her anxiety and mirtazapine for associated depression. She stopped requiring dialysis after around 5 months since the initial transplant, I believe. So follow-up after 4 months since transplant, tacrolimus levels were within normal range, and she was following up with the transplant team, and the PET was also negative. Follow-up after 6 months since transplant, with the transplant team, her PET was high at 76, which was suggestive of a moderate use of alcohol. The patient admitted to drinking a few glasses of wine at a prior wedding, and then again also had a couple of mixed drinks. The transplant coordinator reached out to her, and then she was advised to refrain from drinking, and then eventually, I believe she sought Dr. Sengupta for hepatology in a multidisciplinary setting 7 months post-transplant. At this time, fibroscan was performed, showing mild steatosis, no fibrosis. Unclear if the steatosis came from the recent alcohol use or from the donor, whose biopsy showed 40% macrovascular steatosis at the time of transplant. She was eventually started on naltrexone, 50 milligrams PO for alcoholic cravings, and clonidine for PTSD, and she was amenable to start virtual IOP.
So my question to the group is, first and foremost, how do you deal, and maybe this is mostly for Dr. Post, who's at another transplant center, but to anyone, how do you deal with relapse after transplant? And specifically, is there a protocol for patients who are transplanted under the diagnosis of, acute alcohol-associated hepatitis? Do you have a standardized post-transplant protocol for these patients?
Yes, sure. We definitely have a protocol. Whether it's followed by the patient like we request is another matter sometimes. So our protocol is the patient has to enter a treatment program after they are transplanted. They have to commit that they're going to do that beforehand. They have to sign a contract before their transplant. They have to, of course, it's not a valid contract in a court of law, but it's saying that, they're committing to going to a treatment program afterwards. If they don't, then you can bring that up to them that they agreed to do that. And then they're supposed to do a treatment program and participate continuously in a treatment program. I think that alcohol use disorder is a chronic disorder. It isn't often where you just get somebody through and they're fine. They oftentimes have cravings again. And I think the way to deal with the cravings may be partially with some of these medications, but also it requires counseling, and it requires that the patient have a plan about what to do when the cravings come back, and how they're not going to drink. If you have cravings and you don't have a plan, your plan will be to drink, and so that's not good. So she's still doing okay despite drinking. I certainly would encourage her not to drink anymore. She may do okay in the long run, she may not. It's a real tragedy to give somebody a liver and have them destroy it for the same reason that they lost their first liver. Not only do they die, but their family goes through the agony of watching them die, and the person who didn't get that liver may well have died. So lots of people are affected by this, not just the patient. I do bring that up sometimes. Maybe a little bit of guilt is helpful here. I don't know. So yes, we do have a protocol. Is it always followed? No. Do we always try to follow it? Yes, but we have to realize a lot of these patients are very vulnerable and they need assistance from the medical community.
Thank you. Dr. Brahmbhatt, Dr. New, if you are seeing a patient like this, let's say they are coming to you either post-transplant or, just seeing someone with sort of active alcohol use disorder, what are your practice patterns in clinic? How much help do you have with medication-assisted treatment? What are your experiences with this?
Especially in someone who's post-transplant, I tend to be more cautious about referring them early for management of their alcohol use disorder with the help of a psychiatrist and a psychotherapist. And that can include medication-assisted therapy by the psychiatrist, especially in someone who's young, and there's a significant recidivism rate of up to 20% in some cases with these patients, and the potential for graft loss and that sort of thing. I think being aggressive early on, even before transplant, is important in terms of establishing IOP for them.
Great.
We have a really good addiction medicine as a group. So I do try to refer everyone basically who I think has alcohol use disorder. I try to just talk to them at every visit to refer them, because I don't personally prescribe like acamprosate or naltrexone. So I do leave it to the addiction medicine specialist to do that. Outpatient, that's what I do, how 50% or less will take me up on the offer, I would say. And then inpatient, if they're coming in with ALCAP, they all meet with addiction medicine in-house.
Great. And is addiction medicine at Metro, is it psychiatry? Is it family medicine? Is it sort of a combination?
Yeah, it's a combination, but I do think there's, you go either way, but we have a good IM group that has extra fellowship in it. So they all have extra training in it.
Great. I think that's all we had prepared for the case presentations. So I just wanted to say thank you, Dr. Chatterjee, for putting together those slides. I know that second patient's medical record probably took you several hours to get through. So thank you for that. Thank you to Dr. Post, to Dr. New, to Dr. Brahmbhatt for your great presentations and your thoughtful comments. And thank you to Scott for putting this together and inviting us to chat today.
Thank you, Dr. Sengupta, for putting together the panel and leading the discussion. It was masterfully done. And I think people have learned a lot and will continue to learn a lot as this was recorded and will be posted on our YouTube channel. So thank you all, and have a good evening.
Nice
Take
job.
care, everyone.
Thank you.
Good night.
Very nice.
Good night.